TALL genetics has been investigated for many years now. And however, the identification of genetic risk factors within TALL is a much more controversial topic. Although we understand many of the genetic abnormalities that occur in TALL, both type A and type B abnormalities, are, as many researchers are now referring to them, the identification of robust, validated risk factors is much more challenging in this cohort of patients. This is partly because the number of patients is relatively small, so putting together these large cohorts to do robust statistics is very difficult, but also because there's actually a very large number of independent genetic abnormalities that you see in TALL. So in terms of the optimal approach to diagnosis, at the moment, there are no kind of widely accepted risk factors in TALL. However, this should not mean that genetic analysis should not be done at initial diagnosis. It is very important to do that. And it's very important to do that for three reasons. Firstly, there is a growing number of patients with TALL that have an ABL-class fusion. Although the number is relatively small, these patients have been shown to benefit from treatment with imatinib or some other tyrosine kinase inhibitor. So it's very important to identify those. In addition, patients with KMT2A rearrangements, formerly known as the MLL gene, have a high risk of relapse as they do in B-cell precursor ALL. So again, it's very important to identify those. And possibly most importantly, it's very important to identify the key genetic lesions within TALL so that people, researchers like myself, can put together large cohorts of patients in order to do robust risk factor analysis and identify markers that can be used in the future for risk stratification. Now, although I said there aren't any widely used risk factors in TALL in terms of genetics, there is the French oncogenetic classifier, which is being used in France to risk stratify patients. And this is based on the mutational status of NOTCH1 and FBOX7, and also the KRAS and NRAS and the PTEN gene. So it's a little profile based on those 5 genes. And patients that have the high risk profile have an increased risk of relapse compared to those that don't. However, this oncogenetic classifier did not validate when we looked at it in the UK using the UCAL 2003 trial, and this is probably because of the MRD-directed therapy that was undertaken in ALL 2003. There are various other gene fusions that you see in pediatric and also indeed adult TALL, and again, it's important to identify these because because we need to build up our level of knowledge about the risk factors, the risk associated with each of these gene fusions. And it will be impossible to do unless robust, good quality genetic testing is done at initial diagnosis on large numbers of patients. One of the projects that I'm involved in is called Harmony, and within Harmony what we are trying to do is pool large clinical trial data sets from contemporary clinical trials with as much genetic annotation as possible so that we can look at risk factors across multiple clinical trials in very large patient cohorts. And that is a typical kind of data sharing or data pooling research project where TALL would benefit from that kind of analysis. So it's very important that at initial diagnosis, the genetic testing is done so that in the future, these cohorts can be pooled by some kind of data sharing project such as Harmony, and we can establish robust risk factors going forward into the future.